Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, we're continuing with our 10-part series entitled the QME Top 10. And today we're in session 8. And today I have a fabulous program for you. I'm going to talk about what is always received as a fascinating series of topics and discussions. And today we're going to focus on a small subset of those fascinating topics. And today I want to talk to you about what's coming to be known in our industry as failed treatments. And many doctors, especially the younger QMEs, are concerned when they encounter examinees who have failed all forms of treatment. In other words, they get to the qualified medical evaluation and the examinee complains that their condition is no better. In fact, it's even worse than the day it was on the day that they injured themselves. And for younger evaluators, this comes as a bit of a mismatch between their experience in clinical practice and their experience in practicing as a qualified medical evaluator. And I find that many of the younger evaluators don't recognize this for what it is. And they don't really understand what's going on, but they do know and they do realize, even if they can't quite put it into words or can't quite put their finger on it, they do realize that something is amiss, something is different, something is contradictory, something is kind of wrong. They feel an unease or a dis-ease inside themselves and they can't quite explain it. But they know that there's some sort of a mismatch between their experience in their clinical practice on the one hand and the examinee who's facing them for the qualified medical evaluation on the other hand. And I want to talk to you about that today, and I want to help you put this into perspective if you yourself have sometimes felt uneasy with an examinee in the workers' compensation system. So I want to share with you some ideas today that are extracted from one of our 6-hour continuing education home study programs entitled Symptom Magnification, Deception, and Malingering. Now I want to start this video by letting you know that in the workers' compensation system and the examinees that we see, you're basically going to encounter two types of examinees. There's only two basic types of examinees. And this will probably come as a new perspective for you. There's only two types of examinees. We have examinees who are bona fide, sincere examinees, and on the other hand, what's the opposite of bona fide and sincere? Insincere examinees. We're only going to encounter two different types of examinees in the workers' compensation system. Those that are sincere and that have a bona fide injury and that have a sincere desire to get well, to get back on with their lives, to get off the workers' compensation system, and to continue moving forward in their lives. And on the other hand, we have those who are not sincere, They have not had a legitimate or a bona fide injury. They don't have a legitimate or a bona fide or a diagnosable condition. They have no intention of letting on or admitting that they're doing any better as a result of the treatment that they're receiving. They have no intention of telling you that they're anything but bad. Is this consistent with your experience? There's only two types of examinees. Now, what the angst, if you will, that our younger evaluators are feeling is a knot in their gut, is a churning on their insides that represents an inconsistency between their clinical practice and their qualified medical evaluation practice. Now, in our clinical practices, and those of you that are watching this video, most if not all of you are in some form of clinical practice. So you'll harmonize with this and you'll resonate with this and you'll realize this to be true, that in our clinical practice, the overwhelming majority of the patients that we see and treat go on to respond favorably to our treatments. Would you agree with that? Okay, let me ask you, if you're a medical doctor and patients come to you for treatment, do the overwhelming majority of those patients respond favorably to your treatments? They do, don't they? They go on and they get better. Now, there are a few, the exceptional few, that don't respond to your treatment and need additional intervention, but those are the exception. The majority get well, they respond to your treatment, and they move onward and they move forward. If you're an acupuncture doctor, let me ask you, do most of your patients respond favorably to your treatments? They do, don't they? They do. You make your assessment, you make your diagnosis, you make your treatment plan, you administer that treatment plan, and the majority of people respond positively and favorably to that treatment, and they go on to do better. They do better. They don't do worse, they do better. Now, there are some, you have to admit, no matter how good you are, you have to admit that there are some people that don't respond to your treatment, but those are the exception. If you're a chiropractor, you'll admit, and you'll probably pound your chest just like I do, just like all chiropractors do, that your treatments, when a patient has been touched by your hands, it's like being touched next by the closest thing to God's hands. Isn't that true? If you're a chiropractor, you get your people well, don't you? Yes, you do. Now, there's some that don't get well, but they're the exception, okay? If you're a psychologist, don't most of your people respond favorably to your treatment? They do. Not all, but most do, except for a few exceptions. See, all of us in our treating practices strive throughout our entire careers to be what we refer to as good doctors. We want people in the community, we want our patients to refer to us as good doctors, as excellent doctors. Now, what does it mean to be an excellent doctor? Wouldn't you like to have your patients talking about you out in the public as an excellent doctor? And if you could overhear them in conversation, what would they be saying that would represent you as an excellent doctor? Well, many of you know that I'm a chiropractor. And in the public, if one of my patients was speaking to another person and they said something like, "The guy's a great doctor, the guy's unbelievable. I went in there and my leg was on fire and he gave me one treatment and he pointed to the spot and he said, I'm going to push on this spot," and he pushed on it and there was a pop and a crack and I got up off the table and my pain was gone. That guy, I don't know what he does, but he's unbelievable. Right? Now, if you're an acupuncture doctor, what would you like to hear your patients saying in the public? How about something like this? "I went in there and I had these terrible headaches, and the guy took out these needles and he put one needle behind my ear and he put another needle on the top of my shoulder, and in 10 minutes I could feel my headaches. For the first time in 6 months, I could feel my headaches dissipating. I don't know how it works, or I don't know how he knew what to do, but this guy's unbelievable. You got to go see him." How about a psychology provider? What would you like to hear your patients saying out in the public? Would you like to hear them say something like the following? "I went into the guy and I had all these problems with depression and my marriage wasn't going good, and we talked about it, and the guy's really smart. He gave me some different ways to think about some different things, and he gave me some tools to use when I have problems with my anger and problems with my depression, and when I use those techniques, I feel much better. So the guy's really good. He's really smart. I believe he can help you a lot. You should go see him. He's excellent. The guy's excellent." Isn't that the type of references and referrals that you would love to have your patients giving out in the public? See, we want to be perceived as good doctors. And some of our younger qualified medical evaluators have been working their short career to become good doctors, to get people well. And they're accustomed to getting people well. Well, they frequently encounter examinees in workers' compensation system who are not getting well, And when you see examinee after examinee after examinee after examinee who does not get well, it represents a disconnect and a mismatch for our young doctors. And I want to talk to you about that today. I want to explain to you why you're encountering this phenomenon, and I want to let you know, basically, how to handle it, how to be able to sleep at night knowing that you're going to be encountering people that, no matter what treatment we provide them, will not admit that they're in any way positively impacted by the treatment. I want to share with you some ideas as to how to handle it. Okay, now as I said, today's material is extracted from one of our 6-hour programs on deception, symptom magnification, and malingering. And I just want to say a couple of words about malingering, and then I want to give you some examples as to how you can spot these phenomena in your examinees in the workers' compensation system so that you don't deliberate unnecessarily over their claim and over their case, so that you simply recognize their case for what it is and simply provide them the benefits consistent to exactly what they're entitled to. No less, but certainly no more. Certainly no more. Certainly you want to focus on providing your examinees with the benefits exactly consistent with what they're entitled to. And that is a recurring theme throughout this discussion. We're not talking about denying benefits. We're talking about providing benefits consistent with exactly what the examinee needs. Okay? So I want to review a couple things for you about malingering so that you can understand why so many of our examinees are failing the medical treatments that are being provided to them. Now, let me just kind of backtrack just a bit and elaborate on our discussion just a minute ago about patients in our clinical practice who get well. They get well, correct? There's an exceptional few that don't get well. Well, it seems that the overwhelming majority of the examinees that we see in the workers' compensation system by the time of the qualified medical evaluation have not gotten well. How many of them actually come to you and say, I don't know why I'm here, I'm completely well, I'm back to work, how do I get off this workers' compensation claim? How many of them say that? It's very, very few. I think in my 20-year QME career, I've probably had less than five examinees come to my appointment and say, I'm perfect, I'm done, I'm well. See, in the workers' compensation system, some examinees will never ever get well, no matter what you do for them. Those are the ones for whom we're providing permanent impairment ratings, right? When we provide a permanent impairment rating for an examinee, that's an examinee that's failed to fully recover from the effects of the industrial injury, correct? We give permanent impairment ratings to those people who fail to fully recover back to pre-injury status from the workers' compensation system. Why are there so many in the workers' compensation system and so few in our clinical practice? Have you ever wondered this? Well, I want to share with you the reason why. And it begins with an understanding of the concept of malingering. So let me just give you a couple of definitions of malingering, and I want to show you how to spot malingering in your examinee before you even ever lay eyes on them in the face-to-face evaluation. so a couple of definitions of malingering. And this first one simply comes from Merriam-Webster's dictionary. Merriam-Webster says that malingering involves the patient, in our case it's going to be the examinee, exaggerating or magnifying their actual complaints in order to sell the doctor on the truth of their claims. Exaggerating or magnifying. So I want you to have your ears constantly perked up for traces of exaggeration and traces of magnifying, the purpose of which are to sell the doctor on the truth of their claims. So that's one definition, and that's from Merriam-Webster. Another definition of malingering is to pretend or to exaggerate incapacity or illness, such as to avoid duty or to avoid work. Okay, so those are from dictionary definitions. Let's talk about the Diagnostic and Statistical Manual of Mental Disorders. This is the Bible for psychologists and psychiatrists. So this is the DSM-4 definition. It says that malingering is the intentional production of false or grossly exaggerated physical or psychologic symptoms motivated by external incentives, such as avoiding military duty, avoiding work, obtaining financial compensation, evading criminal prosecution, or obtaining drugs. So it's intentional. It's the intentional production of false physical or psychologic symptoms or grossly exaggerated physical or psychologic symptoms motivated by external incentives. And this is key to understanding the concept of malingering. You must probe in your investigation of your claim for the external incentive. What's the external incentive that could cause an examinee to malinger, to grossly exaggerate their physical or psychologic symptoms? What's the external incentive? Is it financial compensation? Is it to avoid work? Many examinees don't want to work, correct? Is that correct? Our examinees, they obtain financial compensation in the form of temporary total disability and permanent disability benefits, correct? Correct? So these external incentives are already built in to the workers' compensation system, okay? Now, the DSM-4 goes on to give us some criteria to help us identify malingering in our examinee when it's present. And this is so critical. I want to spend just a couple moments on this to make sure that you fully grasp the gravity of this concept. So the DSM-4 gives us 4 criteria for malingering, and they say that if any 2 of the criteria are present, it's strongly suggestive of malingering. Strongly suggestive of malingering. Now, the DSM-4, I should say, has been criticized on its criteria for malingering. And so there's been some controversy about the veracity of this philosophy that 2 out of 4 strongly suggest malingering. But one thing that we can certainly say, and that one thing is not controverted and is not controversial, and that is that the presence of any 2 of the 4 of these criteria is strongly suggestive of poor treatment outcomes, poor response to treatment, which leads to what we refer to as failed treatments. Okay? So I want you to pay particular attention and probe for the presence or absence of these criteria in your very next examinee. Okay? Criteria number 1 is a medical legal context of presentation. Now, isn't the workers' compensation system a medical legal context? It is. In fact, we call our evaluations med-legal evaluations. So our examinees, 100% of our examinees find themselves in a medical legal context of presentation. One of the 4 criteria, by definition, is already met with 100% of our examinees. Is that incredible? Now, the medical legal context is strengthened when the examinee is a represented examinee, when they're represented by an attorney. That strengthens the medical legal context. It puts emphasis on the legal part of the context. Okay? Okay, criteria number 2. There is a marked discrepancy. A marked discrepancy. What's a marked discrepancy? It's a big separation, a big disparity, a large contradiction. It's a marked discrepancy between the stated level of impairment and the medical history. Marked discrepancy. Now, let me ask you, by the time we see our examinees for the qualified medical evaluation, and they come to us a year after the date of injury, 18 months after the date of injury, 2 years after the date of injury, 3 years, 4 years, I've seen examinees as many as 10 years after the date of injury. And they come to the examination reporting that they're no better. Doesn't that represent a marked discrepancy, a marked contradiction, a great separation between the history and the stated level of disability and impairment? See, we feel there's this notion that patients that receive proper and adequate medical care respond favorably. They get well with time. The healing benefit of time, the healing benefit of adequate professional treatment, the removal of the examinee from an injurious environment and placing them on either modified duty or total temporary disability, all of these things conspire and contribute to an environment that we would expect would cause the examinee to improve. But by the time we see them at the qualified medical evaluation, they have a large stated level of disability that represents a marked discrepancy between the medical history, specifically as relates most likely and most commonly to the mechanism of injury. So always probe for the mechanism of injury and always keep attuned for a marked discrepancy. And what I'm stating, in my opinion, large majority of the examinees who finally make it to our evaluation are going to be sharing with you their marked discrepancy. And what they're going to be telling you is going to represent a marked discrepancy. Third criteria, when it's present. So first criteria was medical legal context. Second criteria was marked discrepancy. Most examinees are going to present to the evaluation having already met those 2 criteria. Strongly suggestive of malingering. What's the opposite of a marked discrepancy? The opposite of that is no discrepancy. The stated level of disability is consistent with the medical history. And see, this is where many of the young doctors, they sense that something's not right, but they don't know what it is. What they're sensing is the lack of consistency. They're sensing an inconsistency. They're sensing a marked discrepancy, and they don't know how to put their finger on it, but they know that something's not well in Denmark. Third criteria is a history of a lack of cooperation. Lack of cooperation. Now, the lack of cooperation can be either with the prescribed treatment program. They can demonstrate a lack of cooperation with diagnostic studies and diagnostic testing. They can present with lack of cooperation even with our evaluation. And I'm going to share with you today in today's video several examples of lack of cooperation with the prescribed treatment program, and I want you to pay special attention in your very next examinee for any of these red flag indicators. Okay? So we'll talk a little bit more about lack of cooperation today. And then finally, the presence of an antisocial personality disorder and antisocial personality traits. And we won't spend any time on that here in today's discussion, but I do go into great detail about how to detect antisocial personality traits in our 6-hour QME continuing education program on deception, symptom magnification, and malingering. Now, since I learned this material, I've made mental notes on my examinees, and I would say that approximately 40 to 50% of my examinees do present with antisocial personality traits. Okay? So it's important to be aware of those, although we don't have time to discuss that in today's discussion. So any two of these 4 criteria are strongly suggestive of malingering, strongly suggestive of poor treatment outcome, and it's going to be strongly associated with an examinee who describes failed treatments. Okay? Failed treatments. Okay? So let's talk about some examples that you may encounter of examinee lack of cooperation with the treatment program. And let's just preface these examples by a rhetoric question. And let me ask you, why would an examinee fail to cooperate with prescribed treatment programs? Why would they? Why would they not cooperate? And I'm going to give you some examples of lack of cooperation, some specific examples, but in general, why would an examinee fail to cooperate with treatment programs? Let me ask you, if you had a bona fide medical condition, actual painful condition, an actual diagnosable condition, and you went to the doctor, and the doctor says, we're going to do A, B, C, D, all these procedures to get you well, what would you say as a patient, as a lay person patient? What would you say? How would you respond to the doctor's instructions? You'd say, okay, how soon can we start? I got to get feeling better. I need to get well. I need to move forward with my life. Whatever you say, let's do it. You're the doctor. I'm here for your help. Let's do it. Let's get going. Right? In our workers' compensation cases, what's missing? What's missing is the eagerness to cooperate with prescribed treatment programs because of an absence of a bona fide condition. Do you get it? Do you get it? Okay? Let me give you some examples as to how a lack of cooperation manifests itself in the medical records, in the behavior of our examinee, as that relates to the prescribed treatment programs. Okay? How about missed appointments or sporadic attendance to appointments? How would an examinee, how would a patient with a bona fide condition maintain their treatment schedule? They would be eagerly following to the letter the treatment schedule, correct? Correct? You remember when Jerry Rice was rehabilitating his knee injuries when he injured his knees with the San Francisco 49ers? He was at the physical therapy facility daily before they opened. Before the therapist even got there, he was there. He was eager to get well. He was incentivized to get well, to recover, to return to play. Unfortunately, in the workers' compensation system, our examinees are incentivized to the opposite, to not get well, to not return to play. What's missing? What's missing is a regimented appointment schedule. they miss appointments, or they have sporadic attendance at appointments. I had some medical records I was recently reading that said the examinee missed 6 weeks of physical therapy appointments while he attended a family reunion in Mexico. Okay? That's a failure to comply with prescribed treatment program. How about an examinee who's late for appointments? As I said, Jerry Rice, he was early for his appointments. How about an examinee who fails to get their prescriptions filled? I can't tell you how many times in the medical records I read month after month of progress reports where it says, still hasn't gotten the Celebrex filled, still has the prescription for Celebrex, but hasn't had time to go to the pharmacy to get it filled. How would a bona fide examinee with a bona fide condition treat their prescription medications? They get them filled. They get them filled immediately. They start taking those medications as those medications are prescribed immediately. Correct? Correct? Bona fide examinees cooperate. Insincere examinees have a history, according to the DSM-4, of a lack of cooperation. Insincere examinees fail to take their medications. Sure, they'll get them prescription filled, but they'll fail to take it. If they do take the medications, they report side effects from the medications. Now, if you're a medical doctor, how many of your clinical patients report side effects to the medications? Compare that to the rate of report of side effects to the medications of your industrial population, and I'm sure you'll find it to be greater. They report that none of these medications are helping, and they're all causing them undesirable side effects. It's a recurring theme. How about an examinee that refuses certain procedures? I see in the medical records that examinees refuse chiropractic treatments, or they refuse physical therapy treatments, or they refuse medical procedures such as epidural injections, or facet injections, or nerve ablation treatments. How about examinees who miss or cancel their therapy, miss or cancel their chiropractic treatments? They go to one physical therapy appointment and they say that the physical therapy made them worse and they don't want to attend the physical therapy. Or they went to the chiropractic treatment and the chiropractor did some crazy stuff and it made them worse. Now let me ask you, in your clinical practice, does this happen? This never happens. It's only isolated to our workers' compensation examinees, because workers' compensation examinees have no intention of getting any better, even though the medical provider and practitioner is fully intent on providing them quality treatment whose purpose is designed to get them better. There's a mismatch. It's called a history of lack of cooperation. Now, if you think that those are just conceptual examples, I want to read you just 3 excerpts from random medical records that I recently received that suggest a lack of cooperation with the prescribed treatment program. So let me share with you this one. Okay, this is a record of an injured worker, and these are internal facility notes where the treating doctor says, this is the primary treating physician writing notes, he says that the patient was left a voicemail message. There was no response to the referral for radiology studies, and the radiology referral, therefore, has been closed. So it says, Dr. Jones, MD, patient was left message, no response. Referral is closed per radiology protocol. So this is an examinee who complained of ongoing symptoms and problems and activity limitations. And the doctor said, okay, well, let's investigate this. Let's run some diagnostic studies. And the examinee apparently is less concerned about the problem than the doctor is, and the examinee did not comply with the request for radiology studies. Here's another medical record. This is a case where examinee was complaining, and was provided for a referral to a specialist for a specialist evaluation. And so this is a letter written from the specialist addressed to the examinee. So this was delivered by U.S. mail. It says, "Dear Mrs. Jones, you were referred to such and such physical medicine and rehabilitation department. Our record shows that the department has made attempt to contact you to schedule an appointment. If you are still in need of this evaluation, please contact our department within 6 weeks and we will reschedule your appointment." Okay, now let me ask you, if you were a bona fide patient that had a bona fide health condition, a painful condition that is interfering with your activities of daily living and is causing you concern and pain, and you're provided an opportunity to see a specialist to help diagnose and to help resolve this problem, how would 99.999% of all patients respond? They'd cancel everything, they'd clear off their calendar, and they'd be 15 minutes early to the specialist appointment. Correct? Correct? What if it was your son or your daughter that was given an appointment to a specialist? What would you do? You'd get the day off from work, you'd pick them up at school, you'd go to the appointment with them, you'd be early, you'd have your paperwork filled out completely. You'd be eagerly awaiting the specialist appointment. This is an examinee who failed to respond to the specialist appointment. What does that say? What does that say non-verbally? It says that the examinee not that concerned. Correct? Okay, finally, this one has to do with failure to attend physical therapy appointments. Most patients in our clinical practice make every single scheduled appointment. They want to get well. In workers' comp, it's frequently different, however. This is a note from the physical therapist. It says, the patient failed to return for scheduled follow-up treatments prior to the attainment of the treatment goals as outlined in the plan of care. Therefore, he or she will be discharged from physical therapy. He will be discharged from physical therapy. So, the physical therapist is interested in working with people who accomplish their goals as outlined in the plan of care. They're not interested in working with people who have no intention of getting well. They're not interested in working with people who have no intention of attending appointments. They have a plan in place for those patients that don't attend appointments. They get discharged so that they don't occupy time, space, and energy in the clinic. And these are just examples of what the DSM-IV refers to as lack of cooperation. So doctors, this is part one of our two-part series on this discussion of failed treatments. I want to conclude today's session by simply letting you know that your practice and your experiences as a qualified medical evaluator may sometimes conflict with your practice and your experience as a clinical practitioner. In fact, sometimes you're going to find the two to be diametrically opposed. Whereas in your clinical practice, the majority get well and the exceptional patient does not respond. In workers' comp, you're going to see vice versa. It's the exception that respond favorably and get well, and the majority go on to not respond and will never get well. And the reason for that is what the DSM-4 refers to as external incentives. And I gave you several ways to identify an examinee who may be motivated by external incentives, who may be motivated. I gave you some ways to identify them. These are the examinees who are in a medical legal context. They present with a marked discrepancy. At the end of the treatment program, they say they're no better. They fail to attend their appointments. They have canceled, no-show, missed appointments, sporadic attendance at appointments. They fail to get their prescriptions filled. They fail to follow through on chiropractic. They fail to follow through on acupuncture. They fail to follow through on physical therapy. They have a history of lack of cooperation with the prescribed treatment program. So doctors, I hope that helps you. In our next session, we're going to talk about how examinees demonstrate their lack of cooperation, number one, with diagnostic studies, including electrodiagnostic studies, and then all of the imaging studies. And then we're also going to talk about how examinees fail to cooperate with your evaluation process. I'm talking about your qualified medical evaluation, your face-to-face interaction with the examinee. I'm going to show you ways that examinees attempt to thwart the process and attempt to not cooperate as a sincere person would with the proceedings. And I'm sure you're going to find this a fascinating discussion. And before we conclude today's discussion, I just want to let you know that we're in part 8 and we'll be finishing this 10-part series very shortly. If you've missed any of our discussions, I strongly encourage you to go back, because this series is about the most pressing topics and concerns that are facing qualified medical evaluators exactly today. All of this material is exactly current to the minute, and it's designed to help bring new perspective to the work that we do. So we have a fascinating series. It's coming to a conclusion here in just a couple weeks. But if you've missed even one of our sessions, I provide links for each of those sessions on the first page of our email blog, which goes out weekly. So make sure to stay up with your colleagues and stay up with our discussions. So in conclusion, I want you to know that it's my pleasure to be with you here today. I look forward to being with you next week's video as well. And for now, this is Dr. Perry Carpenter. I'm wishing you best of success in your career as a qualified medical evaluator.